Hi there, am I audible? Let me know in the chat if you can hear me. Hello, can you hear me? Okay, great. Okay, great. Since everyone can hear me, I'll start the session. Sorry for the delay, and thank you for joining this evening. We're going to cover obstructive lung disease, um, which will mainly consist of asthma and COPD. So we'll go by this case by case, and this will be an interactive session, so I can send the Menti code, and I would appreciate it if you could all participate as well. I'm just going to send the Menti code in the chat right now. So that's the Menti code, which I've sent in the chat. And if time allows, we'll go through a few SPA questions as well. Okay. So this is the first case of a persistent cough. We have a 26-year-old female attending the GP for persistent non-productive cough. She wants to have a second course of antibiotics because an initial course made no difference, and the cough has been persistent for 3 months. Do you mind listing a few differentials in the Menti if possible? I'll just start off the Menti so it's active. Okay, I can see a few answers here. So the answers seem to consist of asthma, allergies, atypical pneumonia. These are all great RESP differentials. But when making a list, we can also think of non-respiratory causes. Sorry, we've skipped ahead. Just coming back to the slide we want. Yeah. So like you guys said, asthma is one of the differentials. Someone mentioned allergies, which is also quite good, which can cause cough, other coryzal symptoms. GORD, with acid reflux, it can irritate the esophageal lining, which can cause cough as well. This is what I mean by broad differentials. COPD as well, obstructive sleep apnea. Okay, great. Moving on to the next slide. So, looking at this patient's history of presenting complaint and past medical history, we can see that the cough is affecting quality of life, causing fatigue, becoming worse with exercise. Anytime there's a symptom like cough, it's worth exploring if there are any triggers to the cough. Common triggers known for asthma, for example, is exercise, cold air, exposure to irritants in the air like perfumes, cough, and in the past medical history, we don't see anything remarkable. We don't see any occupational exposure, which is something to think about as well. We can see here that this patient had their appendix removed 3 years ago, tonsillectomy as a child, recurrent bronchitis between ages of 3 to 6. Something like recurrent bronchitis could fit with the picture of asthma as well. Moving on to the next slide. No remarkable drug history, no allergies. This history of hay fever with the family is also relevant for asthma, as we know. Non smoker. Being a smoker or non smoker can be quite important for differentiating between asthma and COPD, just in terms of which differential you'd consider more, and age of onset as well. So this patient was 26 years old, so much more likely for it to be asthma rather than something like COPD, which is caused by smoking exposure way more. So yeah, works as a teacher, no unwell contacts. Okay, in terms of examination, we can see that there's good air entry bilaterally, normal heart sounds. This again rules out other things like infection, pneumonia. Also, with the cough, we could see that it was present for a long time rather than something like pneumonia, which might be around for a few days and then go away. So, the next question on the Menti is what the first line investigation would be for asthma. Let me just change the slide so you can answer. Let me know if Menti is working. Going on to the next slide. Otherwise, you can answer in the chat as well. Okay, great. I can see some answers come up. Yep, that's great. I can see a few answers there. Pheno, eosinophils, spirometry. Yep, okay. All along the right tracks. It's just about which ones would be first line and which ones would be second line. So just changing slides. Yeah, so first line we have the eosinophil count. Oh, going back. And the pheno as well. So these are the cutoff values. Eosinophil is quite accessible compared to pheno. It'll be within the full blood count. So in this patient's case, we can see that both of them are raised. And the most important investigation that we know about is spirometry with bronchodilator reversibility. As we know, asthma is a reversible airway disease, which means that it responds to bronchodilators. So, an example of how you would work this out would be if you measure the FEV1. So, that's what we see in this graph of how much you're able to exhale and then how it differentiates before and after having a bronchodilator, and then measuring that absolute increase. So the diagnostic criteria is for it to be a difference of more than 200 ml, which we do have in this case. And the percentage increase would be calculating the percentage increase between post bronchodilator and pre bronchodilator. So we're meeting that diagnostic criteria as well. And on the right, we have the obstructive pattern. So at the top, the normal graph that you get for a flow volume loop. And at the bottom, you have the pattern for an obstructive curve. So we can see that the flow, it falls just short of the normal curve. But then usually, if I'm not sure if we can see it in this picture, but usually it means that the volume is about the same but then spread out over a longer exhalation. This is because the air is trapped within the bronchioles when you're trying to exhale out, which means that you have the total lung capacity being the same as always. That's not changed. It's just the amount that you're able to exhale out, if that makes sense, because of increased airway resistance. So when you're trying to exhale, the airways narrow or collapse, which means that the same volume is a bit more dragged out across the curve. Just changing slides. Okay, and another second line investigation that we have is measuring variations in the peak expiratory flow. This is an easy test that patients can perform by exhaling as harshly as they can and seeing the variation, especially during the day. So here we can see that there's about a 24% variability. So there's a lot of peaks and troughs in the graph compared to that of the normal values. So rather than an overall reduction, we can see that there are moments of reduction and then moments where it is almost the baseline that you'd expect. So this is consistent with asthma as well. So management of asthma, once you're diagnosed with it, you would start what is called anti-inflammatory reliever therapy. Also, these guidelines are from 2024, which means it has changed from what we might have learned before. Um, so that involves having a low dose ICS and a LABA, and you're taking it as required, which means when you feel breathless. And you test that out for a few weeks, and if that's not helping, then you continue the same regime, but then you're taking it as you require it as well as regularly. So that can look like these inhalers here, Foster or Symbicort, taking it as required and then also one puff a day or two puffs a day. And then if that doesn't work, we step up the dose of this regime. And after that, you would recheck the pheno and eosinophil count again to see if it's still raised. So then you would try either an LTRA, which is like Montelukast, or a LAMA in addition to the MART regime. So first you would try the Montelukast, for example, and if that doesn't work, you add on the LAMA to the existing regime. And then if once you realize that both of those don't work, then you would refer to a specialist in either case, regardless of whether the pheno and eosinophil count are raised. Just changing the slides. So now in her case, we would have started the first line regimen, which is air, which is giving formoterol and ICS as required. So we can see that a few months later, she's presented to the emergency department with severe shortness of breath. And these are her observations as listed on the screen. So I'm going to start the Menti again, and we're asking which category of acute asthma would this be? Hope the Menti is working now. Okay, we have a vote for moderate. Yep, okay. So we agree that this is moderate asthma. Yeah, so this is the categories we know about with acute asthma. So the peak flow can give a lot of information about which classification of acute asthma it would be, but there are other signs that are more readily available for us to help classify which category it would be, such as respirate, the pulse, if they're able to complete their sentences. And one important use of an ABG in this case, or a VBG, is that you can check the PCO2, well, ideally in an ABG. So if it is normal but have other signs of life-threatening asthma, then that would indicate exhaustion of the chest. So that would come under life-threatening as well. So in this case, you would do a full A to E. So before I go back to this slide, if there's any management steps of acute asthma that you know about, you can enter it in the Menti. As we know, as we're working through the A to E, we'll be able to correct each step as we go along. So you can think of it in an A to E manner. Hope the Menti is working for you all. Okay, we have a few answers like salbutamol nebs. Yes, that's correct. We'll go through everything we can do. So, of course, admission to hospital, oxygen. We can start on 15-liter non-rebreathe mask, which is the most amount of oxygen therapy that you can start off on anyway. And then later on, you can adjust the flow rate according to what the patient needs. And yeah, one of the most important steps would be the salbutamol nebs. So, yeah, and also we'd be giving corticosteroids for 5 days, which would consist as part of the acute management. Um, so we know about the acronym where we have these things. So oxygen, salbutamol, we say hydrocortisone, but it can also be prednisolone. And specifically in severe or life-threatening asthma, you can start ipratropium, IV magnesium sulfate. By the time you reach steps like IV aminophylline, you would need to discuss with senior medical staff because that's quite far advanced, and they might need admission to ITU or HDU for intubation. This you would be doing your A2E reassessing, involving seniors as soon as possible. There are options like ECMO available. So yeah, most asthma exacerbations would resolve with oxygen salbutamol. So that was the asthma case. We're moving on to the next case, which is a 68-year-old man who presents to the emergency department with a 3-day history of productive cough and difficulty breathing. So, in the past medical history, we have COPD, type 2 diabetes, hypertension. Drug history matches with the past medical history, and social history, where we can see that he's an ex smoker. So, what kind of examination findings would you expect in someone who has COPD? Going to start the Menti again. The answers can be part of the RESP exam, but also just general appearance from the end of the bed, anything that you might notice. Yeah, so things like looking from the end of the bed, seeing if they require any inhalers, any bedside oxygen, are they on long term oxygen, and then, of course, the RESP exam itself. So, in general, you might notice increased work of breathing, accessory muscle use. So, there are several things that would show accessory muscle use, such as tripod position, seeing recession between the ribs, pursed lip breathing, unable to complete full sentences. You might be able to see how unwell they are from the observations. So, for example, he has SATs of 85 on room air, and we know that the target for COPD would be between 88 and 92, so it's quite low. And on the chest, you might hear a widespread wheeze, reduced air entry, like we mentioned with the flow volume loop, you might notice prolonged expiratory phase. In general, from long term COPD, you might notice hyperinflated or barrel chest. um, and in terms of if we're thinking about, for example, a COPD exacerbation, you might be wondering, is there an underlying pneumonia causing this? Could it be a viral exacerbation? And heart sounds are normal. And other examination signs we have here are things like no peripheral edema, no raised GVP. So, yeah. So, what kind of differentials would you list based on this history and examination? just change the slide on Menti if you're able to see it. Yep, we have COPD exacerbation as one of the differentials, which would make sense. Although that's the most likely, we should still do investigations to rule out other possible things. So here we have COPD, pneumonia, pneumothorax, PE. So there are several things we can do to see if the examination findings fit with any of these, or if there are some we can immediately take out of the equation. So the evidence we have to support acute exacerbation of COPD is dyspnea, if there's any sputum. With pneumonia, you would have other things. I haven't given the temperature in this case, but you might notice a fever, might notice vocal crackles on examination. Pneumothorax, it might be more sudden onset with the dyspnea. You might notice pleuritic chest pain, or decreased breath sounds on one side, which we didn't have in the examination, but it's important to rule out in a RESP emergency. And then we might think of a PE. Again, if you have pleuritic chest pain, if you have tachycardia, which I think this patient had, you'd think about any risk factors in the past medical history. And then we've also said asthma exacerbation. Again, you'd look for any history of asthma, if there's any improvement with bronchodilators. And then the acute heart failure as well. We had some evidence in our examination just before that it might not be the case. There was no raised JVP, there was no orthopnea, no bibasal crackles. And yeah, of course, you'd look for bronchitis, etc. Yeah. So these are the investigations we might do in this side, a basic set of bedside tests such as ECG, just to rule out any cardiac causes, a RESP viral swab, because many cases of acute exacerbation of COPD might be viral, and one of the most common ones would be rhinovirus, the common cold, and some of the bacterial causes might be determined from sputum culture, but this might not be always done in an acute setting, especially since you might not get the cultures back immediately. So we normally start these patients on antibiotics in case there's an underlying bacterial infection. However, NICE guidelines say that you should only start antibiotics if you can see clinical signs of pneumonia, such as sputum, etc. So bloods, it would be quite important to do an ABG, a full set of bloods like FBC, Usinase, LFTs, CRP. With any RESP exam and RESP causes, it's worth doing TROP, BNP, especially if you're suspecting MI or heart failure. And of course, we do a chest X-ray. So what kind of chest X-ray findings would you find in a patient with COPD? We have the chest X-ray here, so you can list what you see. I'm just going to start the Menti. So if you know about the A to E structure with interpreting chest X-rays, you can answer in that format as well, or just any findings that you've noticed on this picture is fine. Okay, we've got hyperinflated lungs. Yes, that's something we can see. We can also see a flattened diaphragm, maybe a bit more flat than you would see with the regular chest x-ray. And you might notice bullae, which might be hard to see on this one, but sometimes you can see the damaged bronchioles area where the lung markings seem a bit disrupted by the damaged areas or like patches of air. You might also find increased lung markings. Okay, great. So there's a lot we can do for the management of acute exacerbation of COPD. So of course oxygen, but we would be quite careful on starting with 15 liters non-rebreathe because we might kill the drive to continue ventilation with a condition like COPD. And we would also be starting salbutamol in this case. But then it's sometimes we start 2.5 milligrams instead, because if you think about it, a normal dose of a salbutamol inhaler is 100 micrograms. And if you're giving these nebulizers with these really high doses, for example, 5 milligrams would be the equivalent of 50 inhalations on the inhaler. So when you think about it that way, it's important to watch out for the side effects of salbutamol as also increased tremor, etc., issues with heart rate. And then if the salbutamol doesn't work, you'd also start a propium nebulizer in this case. And the corticosteroid dose is a bit different in COPD. So we have 30 milligrams once a day for 5 days. And usually, like I say, we start antibiotics before you might get the sputum culture back just to make sure that they're on some type of treatment if you're suspecting bacterial exacerbation. So amoxicillin, clarithromycin, doxycycline, but you'd also look at trust guidelines to decide the specific antibiotic regime that they recommend. And we would consider NIV if because we're monitoring the PCO2 regularly. If you're noticing highly abnormal values or very acidotic picture like respiratory acidosis, then you would want to start NIV, non-invasive ventilation. So for example, this would also change a bit trust to trust. Here, for example, they've said pH of less than 7.35 and PaCO2 of more than 6.5. You'd also watch the respirate. And also, it would need to be refractory to medical management. So, this is after trying salbutamol, etc. And also, with the consideration of NIV, it's important to remember the relative and absolute contraindications. For example, if you have a pneumothorax that wasn't picked up on the chest X-ray, NIV would further worsen the issue. If you have any type of upper airway obstruction that you weren't aware of, then NIV wouldn't be very effective either. And also, we need to see how a patient would tolerate the mask. For example, if they have a lot of vomiting, they might not be able to tolerate this mask around them. So, it's something to think about and discussion with seniors in ITU, of course. And the management, it's from the NICE guidelines. So, this isn't for acute, this is for stable COPD. So if they respond to steroids, we have a slightly different management here compared to if they do not respond to steroids. So yeah. So we can do a few questions now. It's slightly annoying that the answer pops up as well. So we can just talk through it. That's fine. Okay, so a 34-year-old woman presents with episodic wheeze and breathlessness several times a week, including nocturnal symptoms. Asthma is confirmed with reversible airflow obstruction and raised FeNO. What's the most appropriate initial inhaler treatment? So, based on the guidelines we talked about for asthma, we see that we'd start the regular low dose ICS and SABA as needed. I think the previous guidelines would have said SABA first, but now we start off with SABA and ICS right away. Okay, the next question. A 29-year-old woman has episodic wheeze and chest tightness. Baseline spirometry is normal and FeNO is 18. So do we feel that the FeNO is raised? It's below 40, so it's not raised. Symptoms persist despite a trial of low-dose ICS formoterol as needed. So this looks like, based on the management we looked at, it looks like it doesn't fit with asthmatic features because the FeNO wasn't raised, etc. So what would be the next investigation to support the diagnosis? So although here we've said repeat FeNO after bronchodilator, it would make sense for measuring peak expiratory flow monitoring over 2 to 4 weeks, because this was the other second line investigation we had for asthma in general, to look for any diurnal variability of more than 20%. And C, D, and E. So C and D would be more in a well, it's quite an invasive test, and there are other things we can do before resorting to these steps. And E is more in an emergency. So, yeah. Here, question 3, we have a 65-year-old man with a 40 pack year smoking history, and this fits with COPD on spirometry. He's had 2 moderate exacerbations in the past year, and the eosinophil count is 0.35, which is slightly less than the asthmatic cutoff, which is 0.4. So which long-term inhaled therapy is most appropriate? So they're asking about first-line management for COPD without asthmatic features. So we've got D here, according to what we have here. Yeah. Okay, question 4. We have a 70-year-old man with severe COPD presenting with worsening breathlessness and drowsiness. Oxygen sats are 85% on room air. And with ABG here, we have an acidotic pH. We have a very raised PaCO2 and PaO2 somewhat within normal limits. So what's the appropriate next step in management? We likely have type 2 respiratory failure. Sorry, the PaO2 is reduced. So yeah, we have type 2 respiratory failure. When we have this much of an acidosis, it is valid to think about commencing NIV compared to these other steps, such as increasing oxygen. Like we've said, starting on 15-liter non-breathe would mean that you're killing the respiratory drive to ventilate. And with NIV, it's BiPAP, so you're supporting the inhalation expiration on your own. So yeah. Moving on to the final question. We have a 76-year-old woman with COPD presenting with increased breathlessness, sputum volume, and green sputum. Chest x-ray shows no consolidation. She reports a previous anaphylactic reaction to penicillin. So, as we know with medications, if a patient reports an allergy, it's important to pick up on what kind of allergic reaction there is. For example, if it's just a rash or if it's anaphylaxis. So, the most appropriate antibiotic. So we can see that A is clearly a penicillin, B we know has penicillin in it, C would not be appropriate because we want to treat this condition, D is penicillin as well, which leaves us with E, which is oral doxy. So that was the end of the presentation. Thank you so much. I think Restream has a feedback link, but if not, I'm happy to share a feedback link in the chat. Would really appreciate if you let us know how you found the session. But otherwise, thank you so much for joining.